one of the most frequently requested radiological exam, especially in the emergency setting. And the reason for that is that it covers the cardiopulmonary system. It's cheap, it's easy, it doesn't require any patient preparation, and it's also of low dose. So it gives you like a quick idea of what the patient might be suffering from. So first off, we use it as a screening tool in the pre-employment workup, in the regular checkups. And in the pre-employment, it's actually mandatory because sometimes the patient will be completely asymptomatic, but actually would have some contagious disease, such as TB. We many times would find a cavitating lesion in the lung, and then it's TB and the patient's completely asymptomatic, no cough, no fever, no signs of active inflammation. Most importantly used as a for symptoms, so as a diagnostic tool. Cough, shortness of breath, chest pain, unexplained weight loss, unexplained fever. So in case the patient has an unknown malignancy, and that's why they're suffering from weight loss, one of the main things that we want to check is for lung cancer, which is one of the most common cancers in the world, and also for metastatic disease. So the lung is one of the first organs that a primary malignancy will send metastasis to. We also use it post-biopsy or interventional procedures. So oftentimes when we do lung biopsy, a pneumothorax has to form, like a small pneumothorax. Sometimes when we even do breast biopsy. If you are doing a breast biopsy and you fire your gun, you hit the chest wall, then there is a chance you have done a small pneumothorax. The patient is complaining afterwards from shortness of breath or pain, then you have to suspect pneumothorax. And usually a small thing, it doesn't require like any tube to evacuate the air or anything, but you have to document it still. We also do chest x-rays following pacemaker insertion, tube insertion, endotracheal tube, or venous line, central or peripheral venous line insertion. You want to check the adequacy of the location, and you also want to rule out any pneumothorax. Lastly, we use it as a follow-up, easy tool for inpatients and ICU patients. So you have a patient and you have already established their diagnosis using CT, then the chest x-ray will be the tool that you're going to follow up the progress of the patient, or the position of the lines and catheters that are in the patient's chest. Inpatients and ICU patients are, some of the time they are agitated, they might pull on their tubes, their nasogastric tube, their lines, so you have to make sure, like every day, that these are in the adequate location. You have to make sure that the patient did not develop any new effusion, which is fluid on the lung, or atylexis, which is lung collapse. So you want something that is the lowest dose you can get of radiation, which is the chest x-ray, just to follow up what you already know by CT. So today we're going to go through two checklists. The first checklist outlines our presentation today. That is not good. Let me try to open a different version. So this is the PDF version because it's not working from my. So first thing, when you are presented with a chest x-ray, first thing you do is the identification. You want to make sure that this is the right patient. Okay, so you check the name and the medical record number. And you compare it with like depends what you're doing. If the file that you're holding for the patient, this is the patient I'm checking in the ER, or if you're a radiologist, I'm putting a report for this patient, so you want to make sure that these are the same patient that you have the images for. Second thing, you want to orientate yourself with the chest x-ray. And the technologist will almost always put a sign saying left on the left side of the screen or right. So when you're checking a chest x-ray or any imaging, so it's as if you're looking to the patient face to face. So the side of the patient will be opposite to you. Or sometimes you say it's as if you're shaking hand with the chest x-ray. So the left side of the patient is towards my right, okay? So the second thing is the L for left. The third thing you want to know is the position of the chest x-ray. And we have few positions for the chest x-ray that we will discuss later, but the most common one is the PA, the posterior anterior, okay? So in case you haven't been before, this is the X-ray suite. So this is the X-ray tube where the X-ray beam emerges, and this is the detector, okay? So the detector is the plate that receives the X-ray beams after they go through the patient, and they have been attenuated by different biological tissue. So each tissue will attenuate the X-rays, and you remember, I'm sure from before you studied the physics of the X-ray. So each biological tissue will attenuate the X-ray photons to a certain degree, emerging it as a certain shade of gray, right? So the X-ray beams emerges from the tube, hits the patient through his back, and comes out to the detector or the screen film. Okay, so it depends if you have like a digital imaging system, or you still have the analog system, where you know the screen films that we used to use before, right? Okay, if the patient is doing the X-ray in the anteroposterior, so this means that the X-ray beams will hit the patient through the front and gets out from his back. So his back is the one closer to the detector or the screen film. Okay, and this is important. We'll explain why later, because it changes how you look at things. So ideally, is the posterior anterior is the best position, but sometimes the patient cannot stand up, or is in the ICU or an inpatient, so we use the anteroposterior. The lateral position is the next, second most used X-ray, and it gives you a different, like an additional set of information about the chest X-ray that you're looking at. So in the lateral position, the left side of the patient has to be towards the detector, okay? So the X-ray beam will enter the patient from his or her right side. Again, when the patient cannot stand up, so in sitting or position or lying down, again, her left side will be towards the detector on the table. Okay, and this is like we rarely do the lateral view in line position. I'll explain to you why. Okay, so those are portable X-rays machines. So they're similar to the ones we've seen in the MRC, but they're portable, they're smaller, they're like easy to move around, and this is what the technologist will take to the inpatient's room and the ICU, so that they can take the images there without moving the patient or bringing them down. Patients who has to stay monitorized or has fear of infection, or they are the source of infection, so all these we use the portable for them. And this is a small screen where the technologist is able to immediately detect the quality of his image, if he needs to repeat it or not, before he sends it to the PACS. Okay, so what is the difference between the AP, the anteroposterior, where the X-ray goes through the patient front to back, or the posterior anterior projection, where the X-ray goes from the patient back to front? So when you're doing the PA projection, the X-ray source is farther from the patient, okay? You have the MRI suite, the size of the room, you have the facility to do that. So this causes the X-ray beams to be more focused, right? And less radiation to the right is the closest to the detector. And some people will give the example, remember when we used to do, in the dark, we do shadows on the wall. And the more you take your hand away from the wall, the bigger the shadow would get. So the heart is a very big organ within the chest. So the farther it is from the detector, the more magnified or enlarged it's going to be. It will give you a false impression that it's actually enlarged, while it's not. So you have to be careful when you're looking at an X-ray if it's a posterior or anteroposterior. So if someone asks you, can you comment on the heart size? If it's an anteroposterior, then you cannot. Yes?
I think that the size of the heart can be measured with the diaphragm. It should be 1/3 from the length of the diaphragm.
1/3 from the length of the diaphragm. Yeah, but still, all these like organs or tissue will be magnified if they are farther from the detector. Okay, so the heart will be magnified, even if you measure it as 1/3 of the diaphragm. You will. I'll show you an X-ray showing. Maybe it's the next one. Yeah. So this is a PA versus an AP. So the diaphragm is the same, almost the same in both. But you will notice here that this line is longer than the other line, and they are the same patient, right? So it gives you an apparent increase in size of the heart. So you really cannot comment, like you're not supposed to comment on the heart size in an AP. And that's what we usually say. The other perk of doing the posterior, you will notice before that the patient here, this is actually one of our technologies, he put his hands to the side of the detector, right? So he pulled his scapula away from the field of view, like you see here. You don't see a shadow of the scapula. But here, you see this sharp line. So this is the shadow of the scapula. You see the arrow? Yeah. Okay? So the shadow of the scapula, sometimes it's going to confuse you as pathology, or it can cover any pathology underlying. Oops. Okay. The other thing in deciding the quality of the image is the inspiration. So the patient is requested to stand still and take as a deep breath as they can, okay? And this is important because it expands the lung. It makes you see the lung tissue devoid of most, like, interstitial markings. It kind of flattens the middle mediastinum, which is the heart and the vessels and the trachea and the esophagus. And it brings the diaphragm down, so it clears these two areas, which is called the Kostrophenic recess. We'll go there in anatomy. So the better deep breath you have, inspiration to have, the better information you can get from your X-ray. And ideally, you want the patient to be inspired that you're seeing down to the 9th rib, okay? But anywhere between the 7th and the 9th rib is good enough, right, for the inspiration. So here, the patient had an adequate breath. So you see the difference between here with a good, adequate inspiration and here with an inadequate inspiration, right? And this patient, they have nothing. Like you would think, oh, there is some density here, some density here. Maybe they have fluid in their lung. Maybe they have like edema. What are all these interstitial markings? No. Or maybe the mediastinum is widened. No, this patient was sitting, inpatient, sitting position, not standing. Can't take a deep breath. So all the artifacts I'm seeing here, and it's also an AP, you will notice the scapula here. So all this contributed to the fact that I'm not seeing everything well and I can call the diagnosis, even though the patient has nothing really. Okay. So that's the importance of inspiration. The only time that we don't want to take a deep breath more than we need to is when we're looking for a pneumothorax, right? When we're looking for air, because you take a deep breath, you expand the lung. So if there is a small air pocket of air between the pleura and the lung, then the lung can hide it and you won't see it. So when you're suspecting pneumothorax in a patient post-trauma or post-procedure, then you don't tell them to take a deep breath, okay? The one other quality is the penetration of the X-ray. So, like the chest X-ray, and every radiological exam has a set KVP and MA, and the technologists, they know it, and it's already automatically installed on the machine. But sometimes you are faced with an overweight patient, so you need to adjust your setting a little bit. And while doing this, some mistakes can happen. So this is an underexposed X-ray, and this is an overexposed X-ray. Okay, when we see this, before we used to say that the patient is burned, right, because of the amount of radiation that actually went through them. So in both cases, you will see here that the spinal column is completely white. You are unable to see the intervertebral disc or any details, not like this one. So this is the normal X-ray. You have to see through the chest and through the heart. You have to see the intervertebral disc. Not completely like very obvious, but enough that you can detect like large pathology. If you don't see that, so this means that your film is either underexposed or overexposed. Okay, and then you can tell this from the lung. If it's more white, then it's underexposed, so less radiation has gone through the patient. If it's completely black, then it's overexposed. The last thing is the rotation. Okay, so the patient needs to be like completely flat and parallel to the detector with their chin up, and to make sure that the spinous processes, here, do you see them? Do you see the spinous processes? Yeah? Are at an equidistance of the medial side of the clavicle, like the magnified image here. Okay? So this is the medial side of the right clavicle, and this is the medial side of the left clavicle. And you want it to be like at an equidistant, like right in the middle between these two, so that you would know that the patient is not rotated. So what happens if the patient is rotated? You see, this is the medial side of the left clavicle. And we know this is the left because the pacemaker lead is on the left. And this is the medial side of the right clavicle. And those are the spinous processes. So the orientation is completely wrong, right? So you will detect, you will see, oh wow, the mediastinum here is very wide, and the heart is enlarged, and everything is wrong, right? So you cannot, accept this X-ray. And luckily, our technologists are very good, well trained everywhere. So they know that they check their images before sending them to you to read it, the clinician or the radiologist, and they will change it. They will take another one. Sometimes the patient is bedridden or comatose, and then they will need the help of a nurse or a companion. They put their lead apron and they make sure that the patient is stabilized in place, head in place, not rotated. Okay, so down our checklist, the next point is the comparison, right? Whenever you have your checking any rad exam, you need to check the if there is any older exams. They help a lot in everything, not just chest X-ray. So this patient, when I look at his X-ray today, before I freak out about the findings and what's going on, if I see the comparison, I would know that the patient is post-operative, okay? They had a mass in their upper mediastinum and it was removed. So anything I see here, a bit of pneumothorax, and this is a thoracotomy tube, and just some edema following the surgery. When I look at this patient, I would know that this patient is getting worse. I'm seeing an increased density or opacity here in the middle lobe of the right lung that was hardly seen on this X-ray. So I know, okay, so I can tell the clinician, or I can tell myself if I'm the clinician, this patient is getting worse. Okay, this patient is getting better. If I get this, I know that whatever the pleural effusion here, this marked increased opacity that's covering almost the entire right hemithorax is now much less. I'm seeing more lung. I'm seeing a thoracotomy tube here, so I know that the patient underwent drainage of the pleural effusion. Okay, let's go for the anatomy. And this is a diagrammatic anatomy to what is actually to what you actually see with the chest X-ray. We never see the thyroid gland or the thyroid cartilage. We don't go that high up to include the neck. Our main aim is actually to go as low as below the diaphragm. That's our main aim. This is what the chest X-ray requires from us, is to check at the upper abdomen. Okay, so this is a bit exaggerated, but you see the trachea, which is like an air column, right? You don't see the esophagus; it's hiding behind the trachea. You see the heart, and I don't know if you're able to see the outline of the heart here, and it tells you what each margin is made of. The right atrium, the right ventricle, the left ventricle, which forms the apex of the heart, the left atrium, and actually what forms this margin is the left atrial appendage, and the pulmonary artery, and then there is the aortic knob. And then you see the bony structures that overline. So you have the manubrium sterni, the body of the sternum, and the xiphoid process. You have the clavicle, right, with the distal clavicular articulation. You have the upper part of the humerus. Okay, and you have the ribs from 1 to 9. As we said on the chest X-ray, you see down to 9. You see the costal cartilages. You see the pleura, the recesses, what else? So yeah, this is basically it. This is what you see. And what you see, you have to comment on. Like, you cannot miss a bone lesion that's within the field of view. So you have to be very systematic when you're checking the X-ray. Okay, so this is the chest X-ray anatomical overlay, and you see that here it's outlining the pleura, the pericardium, right, and the diaphragm, and it's showing you the fissures of the visceral pleura, so that we have the parietal pleura at the outer side, and then the visceral pleura that goes and divides the lobes of the lung. So you have here this oblique fissure. It divides the left lung into upper and lower. Okay? So what is this part? Who knows what this part is? The one that's bordering the left ventricle or the apex of the heart. Sorry, what? So it's called the lingula, right? And so the left lobe has only 2 major lobes, the upper and the lower. But the lingula is considered to be an additional lobe, but it's actually not formed by a fissure. It's formed by the interface of the apex of the heart with the left upper lobe. Okay, and this is that projection. the lingua. So when you see any abnormality here, you want to call it lingula. You don't want to call it left lobe or upper lobe. Okay. On the right side, we have two fissures. One is transverse, and one is oblique. And again, the oblique divides the right lung into upper and lower. The transverse further divides the upper lobe into upper and middle lobe. Okay? So when you're looking at a chest X-ray, the lower zone on the chest X-ray here, that is bordering the heart, is actually the right middle lobe. It's not the lower lobe. Okay? You have the diaphragm here, and the interface of the diaphragm with the parietal pleura, it's called the Kostrophenic Angle, and this is the first place that pleural diffusion would accumulate, which is lung fluid. You have the trachea here, and you see the column of air. You can appreciate the difference in density between the air, which is like more black, and then the white bone. And the trachea, you see the main division, which is the right main bronchus and the left main bronchus. In this area, we call it the carina. Okay, the point of. Okay, so the second checklist that we're going to go through today is how we're going to approach when we are trying to detect abnormality in the chest X-ray. So there is an inside to outside approach, and there is an ABCDE approach. The inside to outside, where you start with the mediastinum, and the mediastinum is the trachea, esophagus, heart, great vessels, and hilum. Okay. And we will see an image in a moment now that will show it better. Then after you finish the mediastinum, including the heart, you will check the lungs, spaces, the kostrophenic recesses, the diaphragm, above and below the diaphragm, the pleura, and then the chest wall, so inside out. The other approach is the ABCD. Okay, so A stands for airway, so you will check the trachea and the both main bronchi. B is for breathing, so you will check the lung spaces. APCs, you have to always look at the APCs. It's one of the hidden areas that people miss sometimes, and it's very important. It's where the pneumothorax, the smallest pneumothorax, will appear in the apex, and also many masses or tumors would hide in this area. And then C is for cardiac. You check the heart, and we'll see here what makes the margin of the heart. So you have here the right margin of the heart is formed mainly by the right atrium, okay, and more up is by the superior vena cava. The left margin of the heart is made by the aortic knob, second, the pulmonary trunk, which is the main pulmonary artery, then the left atrial appendage, okay, so this is part of the left atrium. It's like a small recess or finger-like projection, and then the left ventricle, okay. The interface of the lung with the heart, or the mediastinum in general, forms few stripes and lines, okay? So the interface of the lung with the trachea forms the right paratracheal stripe, and there is no left paratracheal stripe, or it's not something that we see or comment on. So this is a very thin line. If this thin line gets increased in thickness, like to more than 2 to 3 millimeter, then we have to suspect pathology. Fluid, hemorrhage, lymphadenopathy, which is enlarged lymph nodes, pathologically enlarged lymph nodes. Okay. How about the para-aortic line? Okay, so this is the interface of the lung with the aorta. Again, if the para-aortic line is obliterated, it disappears, or if it's thickened, then I have to suspect there's something wrong with the aorta, maybe dissection. Okay. Paraspinal line. Okay, this line, I no longer see this nice demarcation, then maybe there is a problem in the paraspinal region, which is usually an abscess or again a hematoma. The Azygo osophageal recess also can be obliterated, and this is the interaction of the lung with the esophagus. So it's like a fluid filled place or recess. It's bordered by the spinal column, the esophagus, the heart, and the pleura. And again, if it's thickened or obliterated, then I have to suspect that maybe there is an esophageal disease or tumor. So this is in cut transverse section into the mediastinum. And the mediastinum is this irregular shaped structure right in the middle of the thorax. So it's bordered anteriorly by the chest wall and posteriorly by the thoracic vertebra, and then laterally by the lungs, and then superiorly it just connects, continues with the connective tissue of the neck, and inferiorly with the diaphragm. So this is a sagittal section, or like a lateral view of the thorax, right? So you have the ribs here are anterior, and the thoracic vertebra is posterior, right? You have the diaphragm, and this is mainly what makes the mediastinum. So the mediastinum we divided into superior mediastinum, which mainly contains the major vessels, the top of the major vessels, and the upper thoracic vertebra. We have the anterior mediastinum, which is the retrosternal space, so it's right behind the sternum, and it should be like an empty space. So any mass lies here, this gives me a differential, because the anterior mediastinum is a location of the mediastinum where there are few things, okay? So one of the things that it has a thymus. You see this small triangular shaped fatty tissue, okay? So this is a thymus, and sometimes thymus would form tumors, being it malignant or benign. So when I see on the X-ray that it's an anterior mediastinal mass, I already almost suspect the diagnosis, and I know how to direct the patient for more investigation. The middle mediastinum mainly contains the heart and, of course, the pericardial sac, the remaining vessels, and the posterior mediastinum is the retrocardiac space. Okay, it's another important space to make sure that it's clear. So it contains the retrocardiac space and the remaining thoracic vertebra. So the thoracic cage, we already talked about it. So there are 12 ribs in the thoracic cage, 12 pairs, and they connect posteriorly to the thoracic spine, and anteriorly they turn into costal cartilage. Here. This is a costal cartilage, okay? They turn into costal cartilage, and then they connect to the sternum, the menuprium, the body of the sternum, okay? No connection with the xiphoid. So the ones that connect are from 1 to 7, okay? These are the ones that connect with the sternum. So the costal cartilage have a costosternal joints, as well as the costovertebral joints and the costospinous joints. From 8 to 10, so number 8, number 9, and number 10 rib, they will connect to the costal cartilages above them. Each one will connect to the one on top of it. The rib number 11 and 12 are free floating, so they don't have any anterior attachment. They just blend in into the abdominal muscles, the anterior abdominal muscles. Okay, so this is a fairly positioned and inspirated chest X-ray, but we see here down to the 7th rib only, and this is how you count the ribs. Okay, you count the dorsal ones actually, not the anterior ones. Okay, because these are the ones that you will be able to see better. Okay, the cardiovascular anatomy, we already talked about it, but this is like an additional diagrams just to show it, just to show how it looks like. So on the frontal radiograph, the upper right heart border, as we said, is made by the superior vena cava and the lower by the right atrium. Any pathology here is probably related to these two structures. On the left side, you have the aortic knob, which is part of the aortic arch. You have the pulmonary artery, and then you have this small part is the left atrial appendage, and then the left ventricle. The right ventricle does not form part on the frontal radiograph. It's in the anterior part of the heart when you're looking at the frontal X-ray. So on the lateral, you see it here anteriorly, right? So you have the anterior mediastinum here, or the retrosternal space, and then the anterior part is made by the right atrium and the right ventricle. And you know that by X-ray, sometimes you need to diagnose which cardiac chamber is enlarged, especially in the pediatric group, because then you can reach the diagnosis of what kind of congenital heart abnormality this patient have. And that's why this is very important that you would know which portion of the heart is actually protruding. The posterior aspect on the lateral view is formed by the left atrium and part of the left ventricle. This yellow line is the inferior vena cava, and we see it here because this is the diaphragm, and we see it here joining the right ventricle. Okay, not the left ventricle, so don't be confused by this. The diaphragm, the right side of the diaphragm is very well demarcated. We can see, or like the demarcation of it all through the anterior or the retrosternal space. Okay, but the left diaphragm, which is the higher level diaphragm on the lateral view, you only see it till reaching the heart. And the reason for that is that the left hemidiaphragm and the apex of the heart is on the same side, right? So once the heart and the diaphragm join together at their interface, the organs that are below the diaphragm is similar to those of the heart. So everything gets blends in, like you cannot differentiate it from one another, okay? But the right diaphragm, you need to see it all through. If you don't see it, because then maybe there is a defect in the diaphragm, maybe there is hernia, and we'll see images later. The hilum is an important part of the chest X-ray to identify, and the hilum here, which is the side structure, here it's mainly caused by vessels and the bronchi. The lymph nodes will not show unless they are pathological, okay? And the hila, usually the left hila, is always above the level of the right hila, and the relationship of the arteries is different on each side from the in comparison with the bronchi. So this is again the fissures that we were talking about, caused by the reflection of the visceral pleura and how they are dividing the lung. So on the frontal radiograph, you cannot see the oblique major fissure, like you cannot see them well on the frontal radiograph. But for you to know that this is how the lung is actually divided on the frontal radiograph, you have the two upper lobes, which is similar to one another, and then you have the left lower lobe, and in comparison to it, you have the additional, this is also upper lobe, and then you have the middle lobe, and there's just a small lower lobe on the right, okay? In the lateral, it's better. In the lateral, you're able to see both fissures. On the right, you have the white line, is the oblique major fissure, and it separates the lung, as we said, to upper and lower lobe, and the minor fissure, which separates the lung to upper and middle lobe. The blue line is the only line that goes through the left lung, and it separates the lung into upper and lower lobe. Another way of communicating the findings on X-ray is that you can use zones. So the hilum causes the, we can like call the lung like a central lung and peripheral lung. You know, the central lung is surrounding the hilum, and so you can, this is how you like diagnose it. So you'd say perihilar or in the central. And then there is the upper zone, middle zone, lower zone. So if you see something on the chest X-ray, and you don't have to worry about naming it per lobe if you don't know. You can just say middle zone or like mass in the upper zone of right upper zone of the lung or in the left lower zone of the lung. The Azygo lobe is a normal variant, and it's not actually a lobe, it's just an interface of lung and an Azygo vein that forms this structure, and sometimes it gets like more thickened when there's fluid in the lung. So this lateral X-ray here, I don't know if you see it well or not. So we're pointing here at the right major fissure and the right minor fissure. And this is an abnormal lung because this patient had mitral valve replacement and they have edema and fluid in the fissure. And I'm showing it to you because it delineates the fissure better. Like when they have fluid, then now you can see it better, right? The right major fissure and the right minor fissure. And on the left lung, the left major fissure will be along the same line. The lungs are further divided into segments, and this is by the division of the bronchi and bronchioles. Okay, so when we're discussing CTs, not X-rays, when we're reporting CTs, as much as possible, we want to call it by its segment, okay? Especially for describing a mass. It's important for the clinician and for the person who's going to do like a lung biopsy or something, for them to know as many details as possible. Okay, so we talked about this, the X-ray production, and so that you would know like the different shades of gray. So the air is the least opaque and the most lucent, and the metal and bone are the most opaque and the least lucent, okay? And then the soft tissue is in the middle, is the most gray in the middle, okay? So, okay, let's talk about the lung abnormalities. What kind of lung abnormalities we see? So actually in everything on X-ray, you can see increased density and you can see decreased density. Mainly in the lung, you will see increased density. Most of the pathologies will appear as increased density. The lung is black, right, because it's air. So any increased whiteness, be it focal or diffuse, like focal is just a small place or like the entire lung, this is an abnormality. Sometimes amongst the lucency of the lung, you can see decreased density, which is increased lucency, right? And this happens when the patient is suffering from emphysema. Okay, or if the patient has formed a pneumatocyst, which is a lung cyst, like an air-filled cyst within the lung, right? So it will be more lucent. But the more common things that we check the chest X-ray for is the increased density. So the increased density has different patterns. It could be just a focal area of fine lines or a diffuse area of fine lines, and we call it interstitial, okay? So if it's focal, just a small triangular part, then it could be a beginning of an inflammation or pneumonia or as we see in COVID now, ground glass opacity. If it's more diffuse, then it could be related to either pulmonary edema or cardiogenic edema of the lung, or it could be related to acute respiratory distress syndrome, also shows diffuse increased interstitial increased density, what could it be also? Oh yeah, and also interstitial lung disease, right? So interstitial lung disease is an inflammatory process that destructs the lung, and there are many subtypes for interstitial lung disease. Sometimes it's related to smoking, sometimes it has a genetic predilection. Anyways, it can get so severe, and we'll see a few cases that the patient needs to do a lung transplant. A more dense, increased density, so the interstitial or very fine lines, these are thick lines, and you will notice here that there is no loss of volume, right? The lung is not collapsed. So this is fluid-filled alveoli. When the alveoli get filled with fluid or pus or bleeding, we call it consolidation. And it's mainly seen with pneumonia, right? So it's going to be focal, and it's going to be taking, if you notice here, it's taking mainly a segment, right? Because it's following a bronchiole, right? Okay, if it's well circumscribed, sharp, marginated, then it could be a nodule or a mass. And the difference here is size, with 3 centimeters, the cutoff, okay? And the nodules and masses can be either solitary or multiple, and the differential diagnosis depends on whether they are solitary or multiple being metastasis. Solitary could be lung cancer, or if they have some other benign features, then it can be like a hamartoma, okay, of the lung. The last thing is the atylexis, okay, so there is sharp, demarcated, increased density, and usually you will see it bordering an interface, right? And this is because of a collapsed lung lobe. So there is no air within the alveoli, and there is no fluid. So the alveoli are collapsed, nothing is filling them. So you lost the volume of this lobe. And we'll discuss more what the atylexis, how we can diagnose it on the chest X-ray. So we've talked about the lung soft tissue interface, the stripes and lines. We talked about the right paratracheal stripe and the para-aortic line, the paraspinal line, the Azygo-esophageal recess, okay? So all these lines and stripes are the interface of the lung with one of the structures in the mediastinum. And any abnormality of these lines might cause a set of pathologies. So when you're checking the X-ray, you need to check these lines and stripes to make sure that they are normal, right? And inshallah, when you guys graduate, your lives are going to be much easier than when we started, because we used to have film radiography, right? And we used to put it on a light box. And everyone had a magnifying glass. You cannot be a radiologist if you don't have one. So you have to manually magnify each part and, bring it closer to the source of light and that sort of thing. But now with the digital radiograph, you can window, you can pop up the image where you want, okay? So all these areas are you need to pop it well and see it well. And that's why you have to have this systematic approach so you don't miss anything. The other important, of course, there are many signs that you can detect in the chest X-ray, but the most important one is the silhouette sign. And do you know what silhouette means? Yeah, silhouette is the ability to see a shadow of something, even though it's hidden by something else, right? So when you say something is silhouetted, it means you can see it, right? But in the chest X-ray, it's actually used in a different way. I'll give you an example. So this is a chest X-ray, and this is the heart. And the heart has a left margin, right? The apex. So here, with the red arrow, you see the margin of the heart. So this means that the heart is silhouetted. I can still see the silhouette of the heart. even though there is this patch of increased density. So it's not hiding it, I'm seeing it through it, right? Here, it's the same density, but I no longer can see the heart margin. So when we reported in chest x-ray, we would say there is a silhouette sign, which is wrong because there isn't. It's the loss of silhouette. But it's like, this is how it is, and it's, this is how we're using it, basically. So back to this, what is this increased patch of increased density? So this is consolidation, because there's no loss of volume. The lung still has the same size, but there is this triangular or segmental increased density. So it's a consolidation, it's pneumonia. So when I see a lung and I see this patch and I can decide the demarcation, so I know that once I see the margin of the heart, so this pneumonic patch or lobe is not in contact with the heart. It's not at the interface of the heart, okay? It's not the part of the lung that is closer to the heart. So what part of the left lung that is not in contact with the left margin or apex of the heart? It's the left lower lobe, right? The left lower lobe. It's not in contact, so that's why I see it. When I don't see it, this means it's in this part of the lung that is actually in contact with the heart. And we talked about which part of the left lung that is in contact with the heart and actually formed by it. It's the lingula, right? Because we said that the upper lobe of the left lung, when it surrounds the heart, there is this cardiac notch and the lingula is formed. So when I have a mnemonic consolidation such as this one, and I don't see the margin of the heart, so this means it's lingula, right? When I don't see it, it's lingula. When I see it, then I know it's left lower lobe. Okay, and obviously this is, at the end of the day, you're going to treat the patient the same. It's all pneumonia. But if it's a mass, then it's a different story, right? Okay, this is a quick X-ray about the hilum, and you will notice here that the hilum is exaggerated, right? It's enlarged, it's more dense than usual, right? And because the hilum is formed by vessels, bronchi, and also lymph nodes, you can tell why it's causing this. So you have to do a lateral. So once you do the lateral, you will notice that there is these rounded opacities, right? So once you see rounded opacities, and this is the trachea, right, and the bronchi going through it, okay, the trachea is here, and this is the esophagus posterior to it. Can you appreciate the lines? I'm seeing. So you would know that this is lymphadenopathy, right? So this patient has bilateral lymphadenopathy, bilateral enlargement. The differential diagnosis can be like this large. Okay, so just a quick thing about what the Atylexis does to the lung. Okay, so basically Atylexis is the alveoli without air. Like they lost the air in the alveoli and they're not replaced by fluid or anything. So they are collapsed. Okay, usually triangular opacity because it's either segmental or lobar affection, and there's loss of lung volume. Okay, so the lung is not in the same size anymore, right? There is loss of space, and this space, something has to fill in this place, right? So what will fill the place of the lung that has collapsed? So you have the mediastinum will shift towards this area, right? The heart and the vessels and the trachea will go to the side of the atylexis, right? The diaphragm will go up. So if it's on the left side, you will find that the left hemidiaphragm, okay, the left copula of the diaphragm is actually higher than the right. It should be lower, right? So this will tell you, okay, there's a loss of volume here. There's a lung collapse. Also, the movement of the fissures on the lateral view will change, right? The oblique fissure will move forward in case of loss of volume in the upper, or backward if it's in the lower, right? On the PA view or the frontal radiograph, the transverse fissure will move up if there is a loss of volume in the upper lobe and will move down if there is loss of volume in the middle lobe, okay, not the left lobe. Transverse fissure has nothing to do with the left lobe. Of course, if the atylexis of the collapse is very significant, then it might affect other lobes as well, right? The location of other lobes. So this is what we were talking about, the example that we were talking about the demarcation, the line where you can detect whether you can see the margin of the heart or not. Okay? And you cannot see the margin of the heart here. So we know this is a left lower lobe consolidation. I don't see the margin of the heart. I should see it here, but it's not seen. I should see it here, but it's not seen. What I see here is the fissure. Okay? Okay, this is another pneumonic patch consolidation. And I can see the margin of the right margin here, right upper margin. So I know this is in the right upper lobe. And I can see it here. In the lateral, it's difficult to see any margins, but here it's well marginated. So here, the right margin preserves its silhouetting, okay? But in the X-ray, I'm going to see, we can see a silhouette sign, okay? So this is a silhouette sign, yeah? Yeah. Yes, it's in the lingua, right? Okay, so these are few pathological cases. Anyone want to guess what we're looking at? This is actually a PA, okay? A PA, posterior-anterior position. This is the left side of the X-ray. And these metallic or structures are sternotomy wires, right? And these are protheses, right? So the patient is post-valve replacement. We put metallic protheses for instead of his valves. And you will notice here that the heart is enlarged. Okay? You see the difference in density between here? Can you appreciate? Does it show to you? There is a different density. There is a line going through. It's very, very faint, right? So this can be caused due to pericardial fluid, right? If the patient has pericardial fluid post-surgery, then the pericardium will bulge this way, and the right atrium is also enlarged, but there is this difference in density, okay? So this is cardiomegaly. Here we see the left kostrophenic recess. It's clear, it's pointed, but it's not the same on the other side. The other side there is increased density, right? And there is like what we call a stenting because there is fluid in the pleura filling the right kostrophenic recess, right? And this is small pleural effusion. And if you're not sure and the patient is not well enough to stand up, then you can put the patient in like lying down in lateral position as we saw previously, and then it will show the fluid level, right? We have here surgical clips in the patient left axilla. So we're guessing maybe this is a female, maybe she had axillary node dissection for breast cancer. Now she has pleural effusion, maybe she has metastatic disease. So the chest X-ray gives you a bit of differential then, so you have to like take this seriously and then ask, okay, I need to ask for CT for this patient. Do we have enlarged heart? Yeah, the heart seems enlarged, right? But the problem is that the patient might be sitting. I'm seeing here a bit of margin of the scapula. So there is a chance it's an AP. It's not marked here. You see this rounded structure and a line going? see it? Yeah? So this is the Azygo slope, that the normal variant Azygo slope that we talked about today. Okay. You don't usually see it. Anyways, okay, so what about this one? So in the chest x-ray, we look at chest, mediastinum, lungs, bones, everything, and also we look the upper abdomen, right? And we look below the diaphragm. So these are the diaphragmatic copula, the left hemidiaphragm, the right hemidiaphragm. There is air, right? Black, there's no markings here, but it's below the diaphragm, it's not above. So it's pneumoperitoneum, right? And the stomach here is displaced. The stomach should be higher up, right under the heart. But it's displaced because of the air inside the abdomen. Yeah. Sorry? I can't hear you. Bowel, it could be bowel perforation, it could be post-surgery. When you do abdominal surgery, there is some air within the abdomen, and you see it, and you report it, but it's acceptable. So yeah, it could be either, or it could be perforated ulcer, any cause of pneumoperitoneum. Okay, this patient has a mediastinal mass, right, to the right side, and mainly anterior. It's obliterating the anterior mediastinum as well on the lateral view. Okay, so this is a right atrial enlargement because it's involving the right side of the heart. Now I have way exceeded the time. Okay, you see this rounded, well-circumscribed masses scattered all over the lung areas. Okay, so these we call it cannonball, and it's metastasis. It's a metastatic disease. This is PET-CT, and it's showing an anterior mediastinal mass. This is a dilated tortuous aorta, right? You can no longer see the para-aortic line, right? And this was aortic dissection. You see all this interstitial infiltration, increased density all over, right? Both lungs. And you see here, there is no markings whatsoever here. You see? Can you appreciate that there is no markings here? The lung is collapsed, and all this is pneumothorax, right? Then we put a tube to take this, and then the lung has expanded again. So the pneumothorax is now much less, this strip here, and the lung has expanded again. So this patient had his interstitial lung disease. Okay, this is another case of pneumothorax. There is a loss of the lung markings. So the lung markings is here. So here you do expiration, right? You do expiration so you can see the pneumothorax. And it's a big pneumothorax, you didn't really need to expire. But in case it's a small one. Okay, again, diffuse interstitial markings could be because of edema or interstitial lung disease. This is bronchogenic cancer. Okay, you see here, and there is an additional large mass at the hilum, another mass here, and then the PET-CT shows multiple nodules, right, here and there. And you see why the left hemidiaphragm is elevated this way. Because it's there is loss of volume. The presence of the mass here has collapsed part of the lung, right? So when there is lung collapse, the left hemidiaphragm will shift up. Okay. Okay. Here is a congenital variant that we see. So this is a pediatric patient, and we can see here that there is an additional rib. So the first rib is here, but there is an additional rib going on the left side. A small one also on the right side, so this is called the cervical rib. Okay, I have to stop now because I think this is time for the next lecture. Do you have any questions? No one? This one?
Can you say the presentation